Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary of the JCO articles, Prospective Observational Study of Pain and Analgesic Prescribing in Medical Oncology Outpatients with Breast, Colorectal, Lung, or Prostate Cancer by Michael J. Fish et al., and Prevention of Pegfilgrastim-Induced Bone Pain, a Phase 3, double-blind, placebo-controlled, randomized clinical trial of the University of Rochester Cancer Center Clinical Community Oncology Program research base by Jeffrey Kirschner et al. My name is Jamie Von Rowan, and I am a professor of medicine in the Division of Hematology and Oncology at Northwestern University, Robert H. Lurie Comprehensive Cancer Center in Chicago, Illinois, USA. My oncologic specialty is palliative care and breast cancer. Pain is one of the most feared symptoms of cancer. The fear is perhaps warranted, as pain is commonly under-recognized, under-assessed, and undertreated. This has been well documented by multiple investigations over the last 20-plus years, and in the current issue of JCO is evaluated in ambulatory patients in a study presented by Dr. Fish and colleagues. The primary objective of this elegant and well-conducted study was to assess the prevalence of pain and analgesic use in outpatient oncology practice. In addition, the investigators sought to identify the characteristics of patients who self-reported pain, the adequacy of treatment for moderate to severe pain, and the factors associated with undertreatment of pain. Patients with the most common malignancies, breast, lung, colorectal, or prostate with any stage of disease were enrolled from 38 different institutions, including 13 sites with clinical trial enrollment of minority populations of greater than 40%. A total of 3,123 patients were enrolled. At initial assessment and 4 to 5 weeks later, patients completed a 25-item measure of pain, functional interference, and other symptoms. Providers recorded analgesic prescriptions, and a pain management index assessing the adequacy of treatment was calculated. 67% of the enrolled patients had pain requiring analgesics. Of these, one-third were receiving inadequate analgesia. Of the patients with moderate or severe pain, about 41% of patients were not receiving opioid analgesics, and 20% of those with severe pain were not receiving any analgesics. These findings did not change during the period of follow-up. Identified predictors of inadequate pain treatment included good performance status, treatment at a minority site, and having non-advanced cancer without concurrent treatment. Despite the fact that cancer-related pain can be treated and controlled in more than 90% of patients, pain remains a highly prevalent symptom in ambulatory patients, and its treatment remains inadequate. Numerous guidelines for the management of cancer pain are available. The World Health Organization Analgesic Ladder provides a simple approach to first-line management of mild, moderate, and severe pain with non-opioid analgesics, mild opioids, and strong opioids, respectively. Opioid analgesics are generally readily available in this country, yet sadly, pain management for patients with cancer has not improved since the mid-1990s. The author's observation that patients treated at minority-based sites were more likely to receive undertreatment for pain than those treated at non-minority sites is consistent with observations from previous trials addressing the inequality of pain treatment. The identification of good performance status and non-advanced cancer with outgoing treatment as risk factors for inadequate pain treatment are new observations with important implications for providers and patients. These observations beg for the integration of palliative care across the continuum of the cancer experience. Symptoms requiring treatment are not limited to patients approaching the end of life. Pain in patients with cancer may be a result of the cancer, its treatment, or comorbid conditions. This is underscored by the Kirschner et al. Study evaluating the impact of naproxen on pegfilgrastim-associated bone pain. The investigators randomized 510 patients to either naproxen or placebo on the day of growth factor administration and continuing for 5 to 8 days. Pain severity and duration were reported by patients in daily diaries. The primary outcome measure was the area under the curve for pain, days 1 through 5. The overall incidence of pain was 71.3% in the placebo-treated group and 61.1% in the naproxen-treated group. Furthermore, the incidence of severe pain was reduced from 27 to 19.2% with naproxen. This is an important finding in and of itself. The frequently cited incidence of pegfilgrastim-related bone pain is about 25 to 35%, with a reported occurrence of severe pain of only 5%. This is obviously a gross underestimation of the problem. Naproxen led to a modest reduction in pain incidence, severity, and duration, though 60% of naproxen-treated patients still experience pain. Other agents are clearly needed. This is one of many examples of the underappreciation of the severity and incidence of treatment-related symptoms. Routine assessment and treatment of cancer and treatment-related symptoms are essential components of optimal cancer care. This is what palliative care is about. It is about improving the quality of life of patients by aggressively assessing and managing symptoms due to cancer and its treatment, regardless of the stage of disease or overall prognosis of the patient. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.